Good evening, everyone. We welcome you all to OrthoTV and today we are in continuation of our series, and this is the 10th of this series on OrthoTV original cerebral palsy. And I hand over to Dr. Chasanal Rathod, who's the pediatric orthopedic surgeon and a specialist in cerebral palsy, to introduce today's speaker, Dr. Taral Nagda.
Okay, thank you, Dr. Neeraj. And yes, we are on the 10th webinar for the special OrthoTV Cerebral Palsy series. And I'm sure Nagda sir doesn't need introduction. He's a mentor to all of us. And sir has been like a guide and mentor. Plus, he's like one of the most well-known pediatric orthosurgeons. So we welcome you on behalf of Jupiter CP Clinic and Jupiter Gait Lab, and sir is director and head of the Jupiter CP Clinic and Lab, and I work as a pediatric ortho consultant with him along there. And in continuation to our previous two gait analysis talks, today we are going to take it to a little advanced level, that is analyzing the gait graphs and interpretation of the graphs and implementation of these graphs. So yes, it's been a little difficult topic. That's why we divided it in 3 webinars, and this will be the concluding webinar for the gait analysis. So I request sir to take over this talk for the interpretation of gait graphs. Sir, you're on mute. Yes.
So I'm trying to make this as easy as possible for everybody, and hope I will be able to do that. So this talk is all about interpretation of gait kinematics. It is when you get a report from a gait analysis lab. So how do you look at those graphs and interpret it and then take decision? And I must acknowledge that though I am presenting this talk, I'm acknowledging the efforts of Chasanal, who's here, and Mayuri and Ajay, who are not here on this webinar right now, but who will be part of Jupiter Gait Lab in putting a lot of material together for this talk and making sense of it. So when Chasanal spoke last time about components of 3D gait analysis, she said that there are 2 parts. One is kinematics and kinetics. The kinematics is about angles. It is geometry of walking, and it measures angles in sagittal, coronal, and transverse planes at pelvis, hip, knee, and ankle. So it's geometry. When we talk of kinetics, we measure forces, we measure momentum, we measure power. So it is like physics of walking. So you have on one hand geometry of walking, and the other side you have physics of walking, and together they form what is known as science of walking and also arts of walking. So this is what we see when we see a graph from any gait analysis lab. You will see typically 12 graphs. 4 of these are in sagittal plane, 4 of these are in coronal plane, and 4 of them in transverse plane. The 3 at top are angles from the pelvis. The next row is about the hips. Then there is a row about the knee, and the bottom one is about the ankle. So in all, you have 4 multiplied by 3, which is equal to 12 graphs. Now, one must realize that among these 12 graphs, what we see when we do a 2D or visual gait analysis is only these 3 graphs. The graphs which we see as the sagittal graphs in hip, knee, and ankle, they can be seen by eyes. Other movements are not seen by eyes very clearly, and that's why it's important to look at all the graphs together. It's very important to look at these graphs also and analyze, because changes in one graph may be because of actual changes taking place in another. For example, at hip, if there is internal rotation, it may show as ankle valgus, it may show as knee valgus. Okay, so changes at any one level are also going to affect graphs at another level without actual cause being at that level. And this we will understand if we go through each of these 12 regions one by one, and I'm going to make it very, very simple for everybody. So let's come to pelvis first. So at pelvis, we have 3 graphs. On the left is the sagittal graph, which tells you whether the pelvis is tilted anteriorly or posteriorly. Then there is the graph from front, which tells you is there pelvic obliquity, is the pelvis leveled or it's tilted on left side or tilted on right side. And lastly, you have a transverse plane, which tells you whether the pelvis is tilted, is rotated in front or rotated backwards. Okay, so these are the three graphs which we see. So let's come first to the problems of sagittal graph. And one of the commonest things what we see is a double bump pattern. So what is a normal pelvic, sort of a curve in sagittal plane? It's a smooth curve with a normal, soft waves. But when you have hard waves like this, which forms a double bump pattern, this is known as a double bump curve. And this is something which is striking. And if you have this present, this one bump, and then the second bump, if you have this present, there are very few causes of it. This can be because of hip flexor contracture or overactivity, or this double bump also suggests reduction in hip extension. Okay, so this pelvic double bump is an important sign. Sometimes this may be also secondary to rectus tightness and a stiff knee gait. So presence of double bump always draws your attention to tight hip flexors or tight knee extensors. So that's about double bump pattern. And let's see an example here. So you see a child here walking like this, and you see that she is walking with knee, hip slightly flexed. And this is the way she walks. This is a child with a crouch gait. The center of gravity is posterior to the knee joint. And in this child, you see a double bump pattern here. And this is a double bump pattern with the pelvis turned posteriorly, which indicates that hamstrings are tight. And at the same time, there is some issue with the rectus also. So, this immediately draws your attention to rectus. Okay. So next in the line is pelvic obliquity. And if pelvis is drawn up or down, the commonest cause is leg length discrepancy. For example, if the right side pelvis is on a higher level, it will be because of right lower limb which is taller than the left lower limb. If the left pelvis is at a higher level, it means that the left lower limb may be taller than the right lower limb. But this can also happen because of adduction contracture. For example, you have an arthritic hip on the left side, and if there is adduction contracture, naturally the pelvis will be at a higher level than the right side. Many times, this can also be present in absence of limb length discrepancy. For example, if you have a scoliosis, especially lumbar scoliosis, the pelvis may be tilted. Many times, in cases of hemiplegia, there is no actual deformity. There is a pelvic retraction and elevation of the pelvis, and which may give a false sort of a sense of shortening of the limb, even if when the limb shortening is not present. Okay, so it's very important to look at the pelvic obliquity in totality. You must look at the limb lengths whenever you have pelvic obliquity. You must look at the spine. You must look at unequal cerebral palsy whenever the pelvic tilt is present. Now let's come to pelvic rotations. So normally, when you have a pelvic pelvis, the internally rotates and then comes into center and then externally rotates and again internally rotates. Or reverse pelvic rotation like this is seen when there is overall weakness, because the rotation here is required for ground clearance. When the limb has weakness, say of hip flexors or knee extensors, you may be able to see a reverse pelvic rotation. The pelvis may be, right or left pelvis may be internally or externally rotated. As generally, if you see that, it is a compensation for a torsional problem in femur or tibia. If you see a pelvic rotation like this, asymmetry between right and left side, you must look at the rotational problem in femur or tibia and the foot progression angle, because these may be compensatory changes in the side. Pelvic rotations are also important to look at. And here we see an example. This is a child who is walking like this. The right side foot progression angle seems to be externally rotated. And if you really look at the rotational curves of this pelvis, you realize The red, which is the left side, the pelvis is internally rotated, and blue, which is the right side, seems to be externally rotated. But this is not because of any problem in the hip or the pelvis. This is a compensatory action to the foot rotation, which is seen lower down. So you must look at the curves of the ankle and foot knee so that you can really find out if the pelvic rotation is compensated. So in this case, it was a compensatory rotation, and we should not correct this at pelvic level. When you take care of a rotational problem lower down, this pelvic rotation will automatically be corrected. So I will give you an example that in hemiplegia, many times a child walks with foot internally rotated. Now, if this is a primary pelvic problem, and if you treat this by doing an osteotomy at tibia or femur, what is going to happen is you will be correcting at a wrong level. That's why it is important to note what you see as a deviation in a foot progression angle. Is it because of problem in tibia, femur, or it's a pelvic problem? And that's why, as Chasanal spoke to us last time, the diagnostic matrix is very important. One should look at clinical evaluation, CT scan profile, as well as the rotations on gait lab if you really want to come at the right diagnosis. So this was all about pelvis. Let's come to hip joint graphs, and this is more interesting than pelvis. And when you see hip joint graph, firstly looking at the sagittal dimensions, the hip may be excessively flexed. Very rarely you will have hip which is excessively extended. In most of the gait deviation, hip may be excessively flexed, and most of the time, the causes for hip being excessively flexed are secondary to excessive knee flexion. So, whenever you see excessive hip flexion, you must look at the examination of knee. If the knee is in flexion deformity or hamstrings are tight, that will immediately give you the diagnosis. You must also look at the Thomas's test. So if the child is walking with hip inflection with gait analysis and Thomas's test is positive, the cause of the hip flexion is structural in the hip flexion deformity. But if the child is walking with hip inflection, but if the Thomas's test is negative in that child, the hip flexion is secondary to knee flexion and not because of any problem in the hip joint. Leg length discrepancy can be also another cause of hip flexion as the child is trying to compensate and increase leg length by flexing the knee and the hip. So these are important causes here. And you can see here in this child, give me a minute. Is my screen visible? Neeraj? That's not.
Yes, it's visible.
Okay, now it's visible. So this is a child who's walking, and it's very difficult to make out with naked eye whether the hip is in flexion or not. But you see in this child, she's walking with hip flexed, and it's very important to realize that in this patient, the hip flexion has also given rise. Hip flexion here, you can see the hip is flexed on left and right, has given rise to increased knee flexion in the beginning of the stance phase. Okay, so hip flexion can be responsible for knee flexion because whenever the hip is flexed, the pelvis is tilted anteriorly, and in that case, the ischial tuberosities are raised up, and that may give rise to secondary apparent, knee flexion attitude when the child is walking. So this was about the hip flexion, and you note it here. Now, increase in hip adduction. We really don't pay much, importance to hip adduction and abduction in gait analysis. But if there is a increase in hip adduction, it's important to realize that it is not because of tight adductors. Most of the time, it is a result of increase in hip internal rotation. Okay, so the changes in the frontal plane are most of the time secondary to other factors rather than actual deformity in the frontal plane, and one must look on clinical evaluation on X-rays and on on other grade graphs, what are the reasons for this to happen. So we'll see an example here. This is a child who's walking. She has very mild cerebral palsy, and the complaints here was that she had genu valgum, and you can see she has bilateral genu valgum, and this bilateral genu valgum, you can see that results in appearance of hip being adducted and both the thighs crossing over at knee joint. And you can see this very well on the graphs here that both the hips seem to be adducted. But this is not because of adductor tightness. This is because of internal rotation of the knee. And this is known as pseudo scissoring. So in a child who walks with scissoring, it's very important to rule out a rotational problem in the femur, because you may wrongly end up releasing adductors or doing an obturator neurectomy, whereas what was actually required was to correct the rotation at the femur by doing the derotation postoperatively. So this is the importance of hip adduction and abduction. And lastly, we come to hip rotations. So there can be increase or decrease in hip rotations. If there is increase in the internal rotation of the hip, it can be because of femoral anteversion, or it can be compensatory to excessive external tibial torsion. So whenever you see any rotational changes in the hip, one must look again, go back to clinical evaluation and CT to know whether it's coming from femur or tibial. So you see a hip which is in internal rotation, and on a clinical examination, if the hip is normal, hip internal and external rotations are normal, but the child has thigh foot angle which shows there is external tibial torsion, then the problem is not in the femur but it is in the tibia. But in the with the similar hip rotation finding, if your thigh foot angle is normal, but hip internal rotation is 70 and external rotation is 40, the problem is actually in the femur, and that child should be treated by a derotation hospital. Similarly, increase in hip external rotation can be because of hip femoral retroversion, but it can also be because of tibial intorsion. And this we see many times happening in children with clubfoot. Okay. So here is an example I want to give you. This is the child, and she is walking, with a rotational issue. You can see that there is internal rotation as far as the foot progression angle is concerned. So I am showing here the foot progression angle which is internally rotated, and you can see that that has resulted in the hip being externally rotated. So problem is not here in the hip joint, but actually it is in the tibial torsion. So it's very important to see that what deformity you see on graphs. Your mind should start working, and you should start seeing where is that deformity coming from. This is the training. So training is required to see across the graphs, up and down and left and right. And more graphs you see, more your eyes will get. Coming to the knee, reduction in knee extension, or increase in knee flexion. The commonest cause is hamstring tightness, but this can also be seen because of external tibial torsion or increase in femoral neck anteversion, or it can be secondary to a foot. So this is a child with cerebral palsy, with a crouch kind of gait, and you see here that in the mid stance phase, the knee extension is reduced. We start very well here, in the initial contact, but in the mid stance, you see that the knee doesn't extend that well, and this is combined with increase in the ankle dorsiflexion in the mid stance, and this is typical of crouch gait. And in this case, this was because of hamstring tightness, which is very typical of crouch gait in this patient. So, reduce or delayed knee flexion in the swing phase, on the other hand, is generally because of rectus tightness. So, the moment you see this kind of picture, reduction in peak knee flexion in the swing phase, you must examine clinically for rectus tightness by doing a prone rectus test. But you must remember that this can also very commonly result from a reduced speed. So child who has normal recti but has reduced speed, will also have this kind of problem. So clinical examination in that case, prone rectus case will be negative. Sometimes it can be because of cross-plane interaction if the pelvis and the hips are externally rotated and retracted. So pelvis can also affect the knee flexion, the appearance of knee flexion in many cases. When you see reduction in peak knee flexion, don't jump and call it a stiff knee gait and go on to release rectus or inject Botox in rectus. You must look at other factors, other causes of reduction in peak knee flexion. So this is a child. You can see she is walking with a walker, and if you see her sort of knee graphs, her knee is in flexion to start with, but in the swing phase, there is reduction in peak knee flexion. And this case on clinical evaluation, we found that really rectus was not tight. But there are a lot of rotational issues, and this problem, which was apparent, decrease in peak knee flexion was because of was a result of a rotational issue in that child and weakness, very very slow. So lastly, coming on to ankle and foot graphs. So ankle normally goes in the mid stance phase. It dorsiflexes, and there is rapid plantar flexion towards end of the stance phase. And then for the clearance, ankle goes back again into dorsiflexion. So it is a seesaw graph. Initial small plantar flexion, then dorsiflexion, then a big plantar flexion, and then coming back to neutral. So that's how it happens. But if ankle, the first occur, if it's absent, which means the child starts walking, in equines. The most common cause is calf tightness in cerebral palsy. However, it can also occur in a child with limb length discrepancy. So if left leg is short, the child would like to land on the toes on that side to adjust the limb length discrepancy, and you can see a similar finding. So in hemiplegia, one has to be very, very careful when you see a child walking on toes. There can be three reasons. It can be because of calf spasticity, it can be because of weakness of angle dorsiflexor, and thirdly, it can be because of leg length discrepancy, apparent leg length discrepancy or two leg length discrepancy. The two leg length discrepancy is actual decrease in length. The apparent one is because of the pelvis, which is pulled up. Okay, and that can also cause the child to walk on the toes on the other side. So these are few causes of the first rocker being affected, and you see a child here on the left side, a child with hemiplegia. You see in the graphs that there is increase in ankle plantar flexion in the initial contact, and which continues into the mid stance and into the terminal stance. So this was because of calf spasticity in this child, and injecting Botox in the calf reversed gait of this child. Um, Early ankle plantar flexion can be caused again by calf spasticity, and that was also seen in the previous case. There was an ankle plantar flexion to start with, and then it continued with the next. Now, when we look at the rotations, foot progression angle is very important, and it's important to realize that in Gait lab, when we talk of foot and or ankle angle, it is in relation to the lag and not relation to the tibia. So, if the hip of the child is in external rotation, but TBI is normal, still the foot progression angle can be externally rotated because it is measured in reference to the axis of walking of the child. An external foot progression angle, that's why, can be because of external tibial torsion or a foot deformity, where the midfoot is broken and foot is in external rotation. But it can also be because of a problem in the hip joint or because of pelvic retraction, which typically happens in a hemiplegia. If you have an internal foot progression angle, it can be because of increase in femoral anteversion It can be because of tibial internal torsion, or it can be because of tibialis posterior tightness, which is causing the foot to go inside. But it can also be because of pelvic protraction. So one has to sort of rule out other issues by a clinical evaluation in these children. So to give you some examples here of changes in the foot progression angle, this is the child who's with CP walking with internal foot progression angle right more than left, and you can see the same thing being noted on gait analysis, documented very well that right side there is increase in foot progression angle, also on the left side, but right is more than the left. Now, if you look at the knee angles, the knee is also internally rotated. And then if you look at the hip is mildly externally rotated. So, this means that the foot progression angle is not because of any problem in tibia, but it is because of problem in the femoral torsion. Okay? So this needs to be confirmed, however, with clinical evaluation. It also needs to be confirmed with a CT scan because the changes can be very misleading and confusing if you are not very accurate. So this is again a child who has excessive femoral foot progression angle, which is an external rotation. See, uh, in the same child, when you look at the knee graphs, knee seems to be in hyperextension, okay? And the foot is in external rotation. So again, it's very important here that we look at the correlation between the two. Okay, so correlation between the knee graph and the foot graph. And the knee actually is not in hyperextension. If you clinically examine this child's knee, the knee extension is normal. Then why does it appear to be in hyperextension? It is because of foot being in excessive external rotation. This is the beauty of gait analysis, the 3D graphs. It's very important that you don't look at one graph in isolation. Each graph should be, valued or interpreted in relation to several other graphs. So 11 other graphs which are there on your chart. At the same time, you have to see all these changes in relation to clinical evaluation and the CT scan. So all clinical findings put together as diagnostic metrics will give you the results. So I hope that I've been able to make it a little simple for all of you. To summarize, I would say again that we have 12 graphs. You have 3 pelvic graphs, 3 hip graphs, 3 knee graphs, and 3 ankle graphs. And in each graph, there can be positive or negative changes. So for hip flexion, it can be increase in hip flexion or increase in hip. For ankle, it can be plantar flexion or dorsiflexion. These are all in sagittal planes. In coronal planes, it can be adduction, abduction, or inversion, eversion. And in transverse plane, it can be internal or external rotation. And play of these graphs with time at each joint, temporospatial parameters at each angle give you the complete picture of how the child is walking. So with this, I'm ending this talk and I hand over to Dr. Chasanal Rathod, who will tell you how you put all these 12 jigsaw puzzles together to make one complete picture which makes sense. What do you, Chasanal?
Yes, thank you, sir. And so we are truly aware that how complex these graphs are, and we have spent years trying to understand these and study these and use them day in and day out. And like sir mentioned in the previous webinars, that it's not that in a year we send one patient of cerebral palsy for a gait analysis. It has to be done for every patient, and it has to be made like an habit to treat every child with cerebral palsy with a gait analysis. And that's how we can actually make a difference, and that's how we can bring about changes. So just to continue with the previous two, we first studied, we first tried to learn that what are the difference between a simple 2D analysis and 3D analysis, and when this 3D analysis is extremely important, how to take these videos, and how does gait analysis and instrumented gait lab differ from taking basic videos with the help of a simple device. And when we talk about gait analysis, just like Sir went through with you through these graphs, and I would like to bring about again, like Sir said, that the graph doesn't come with a report. It is up to us to interpret these reports. And just looking at the reports does not give us a solution. It has to be used as a supplementary data with the entire diagnostic matrix. And Sir has also kind of specified this before, and we have been constantly talking about this diagnostic matrix, that how it makes treatment of CP very simple, which is otherwise quite difficult because of the inter-joint relationships or the interplane relationship. And that's how using this data together with each of the other information we have makes a lot of sense in deciding what surgery is needed. So how does the clinical relevance of gait analysis look at in the literature? So there are various papers which talk about this, and they say that how actually does the gait analysis change, or does it make any difference? And yet, yes, it does make a lot of difference. It makes around, so each of these papers, they have quoted the percentage difference which they made after, prior to a gait analysis, what the surgical plan was made, and then post gait analysis, what the surgical plan was made. And we ourselves in our lab and clinic have noticed that we have shifted from doing some sort of surgeries and moved towards doing some other surgeries, which would be, of course, discussing with the case-based examples, which I'll be showing you. So looking at the graphs, we saw that the graphs have been divided into sagittal plane, coronal plane, and transverse plane. I shall show you two cases of sagittal plane, and then we are going to see another one or two case of transverse as well as a coronal plane if possible. So if we look at these two kids, so this is a typical sagittal plane. When we look at the child from the side, it's a sagittal plane gait pattern. We looked in the previous gait patterns that the diplegics are divided into equinus gait pattern, jump pattern, crouch, and apparent equinus. So when we look at these two kids, now they are both 10 years old and they both walk with a crouch gait. Both are diplegic CPs. If we look at their structure in general, the case one is quite a lean child having a similar growth spurt and similar height, but he has a very mild crouch. And the second one is kind of a little heavy kid. He needs a lot of effort, and his gait is quite energy consuming. He bends, his knees sinking. He himself is sinking quite a lot. And what we see here, the ankle off the ground, it's just the apparent equinus. So we'll go into detail of how to interpret this kind of gait and how to make sense in decision making. So if we look grossly, without a gait analysis, people might probably grossly think to do of hamstring lengthening in probably both the cases, but it's not like that. With the gait analysis, we have an added advantage of looking at very fine details which can be missed by naked eye in the clinic or while just watching the observational gait analysis. Or sometimes the observations could be subjective. What I feel may not be what some other surgeon might feel. So that's how the gait analysis comes into role. And if we look at both these graphs, so this graph belongs to case one and this is case two. Both are sagittal plane graphs. So we have skipped the transverse and coronal plane and I've just put the sagittal plane graphs. And if we look at the first child, if you look at this, the pelvis is, so the gray part is the normal part, and the blue is the right and the red is the left again. So, and this line divides it into stance and this is the swing phase. So these graphs ideally should be following the gray pattern because the gray is a normative graph as per the child's age and sex. So here we see that there is a slight double bump and the graphs are although in much closer to the gray pattern and they are not deviated from the normal part. Similarly, for the hip, we look at it, it's quite normal. The hip is not going in flexion. When we look at the knee joint, there is a flexion of around 20 degrees at initial contact. And in the mid stance, the knee doesn't go in extension. And in the swing, the knee is again not able to extend completely. And when we look at the ankle, yes, the ankle is in slight dorsiflexion, but yes, again, it's following the normal graph. So the main concerns here are the knee and slightly posterior tilt of the pelvis, which is not very significant. While we look at this second child, so when we look at it, see it as when we look at the child, it seems like his pelvis is tilted anteriorly. Probably it could be because of the abdominal fat, or maybe because of the fat over the back, but actually his pelvis is tilted posteriorly. His hips are flexed, of course, because he's into a more advanced stage of crouch as compared to the case one. And if we look at the knee flexion, it is around 80 degrees. So he's walking with the knee constantly flexed in around 80 degrees, even in the stance and swing pace. His ankles, what they are showing, they are in dorsiflexion. So if we actually look here, or maybe we discuss this later. Yeah, so let's focus on the knee here. So both of these kids, like I said, we could probably make a plan of doing an hamstring lengthening. So let's look at how the ankles are. Is there a lot of, so we need to correlate it with the clinical data. How much is the knee flexion deformity? How much is the functional popliteal angle? The popliteal angle in 90 degrees of hip flexion. So all these are suggestive of a contracture or a short hamstring, of course. But when we looked at the graph along with this, it is important to understand that it was the pelvis was not tilted posteriorly, and hence we have two options here. So if the pelvis was tilted posteriorly, probably we have a short hamstring, and we should be considering this hamstring for a lengthening. But here, since the pelvis was just following the normal curve, the better option would be probably an injection botulinum toxin or a stretch cast. And then that's how, looking at the graphs, we decided to do a basic injection botulinum toxin for this child and a wedging cast. This is how the child looks at follow-up of 6 months, and that's how the child is doing at 8 months, 1 year. So had we not done a gait analysis for this child, and had we not assessed how the pelvic tilt is or how bad the flexion at the knee is, probably we end up doing over lengthening, or probably we end up doing lengthening for a muscle which doesn't need lengthening. And this child could go in an anterior pelvic tilt, and from this good walking pattern, he could go in probably a walking pattern which would need a support. And this is a 10-year-old, same child again, and we saw how he was walking. He has a very good core control. So all these points which I'm talking about the examination, that I have already covered in the clinical evaluation of CP, and that webinar is also available on the OrthoTV online channel. So here, if we look at the knee FFD, it is around 40 degrees, 30 to 40 degrees. He doesn't have hip flexion deformities. And if we look at the popliteal angle, both these sides, it's around 90 degrees, and R2 is around 80 degrees. We're looking at the opposite side, and we find similar findings. So like we spoke about this in the last talk, that which are the kids who actually need a gait analysis. And this is one of the child. So if you look at him walking, he walks with a knee flexion of 80. But when he's supine, he has a knee flexion degree of 40 degrees. So what he is in upright position is not what he is in supine position. And now we are trying to correct a walking problem by putting the child into a supine position. Posterior tilt here as compared to the case one. You see, this is so much not the kind which we had there, which was in the gray zone. And this is much more behind as compared to posteriorly as compared to the normal graphs. The hips are very much in flexion, but although this is not clinically correlating, we saw in the previous slide, the child did not have a hip flexion deformity. So how does this hip come into flexion? So these are the secondary changes which has happened secondary to the knee flexion deformity, which causes flexion at the hip joint. And if we look at the knee flexion, like I said, this is around more than 80 degrees, which is quite significant here. And if we look at the ankle is actually in dorsiflexion, while it seems to be like there is an equinus deformity because the heel is up. But when we do the gait analysis, this is what differentiates an equinus, an apparent equinus, and a crouched child who walks with an apparent equinus with an actual true equinus gait pattern. So a true equinus kid will have graphs this side on the plantar side. Now our graphs have shifted on the dorsal side. So because the crouch is defined as flexion at hip joint, flexion at knee joint, and dorsiflexion at ankle, So that's how this is a crouch gait. But had these been in plantar flexion, then it becomes a jump gait, and that is an actual equinus. But here this is an apparent equinus. So looking at all
Just
this,
interrupt here. So
yes,
this
sir.
is something which is a big value of a gait
Yes,
analysis, because it prevents you from doing an unnecessary calf length.
yes,
Then this child will stop walking.
yeah, the
The
child
option
is,
is worse.
yes, totally agree.
Absolutely.
So for this child is only 10-year-old. He has this severe deformity of around 30 degrees to 40 degrees knee flexion deformity. On walking, he sinks to around 80 degrees of flexion deformity. So we had multiple options. And upon doing gait analysis, the plan was to do a hamstring lengthening, considering the posterior tilt of the pelvis. Had that posterior tilt not been that posterior, then probably an osteotomy can be considered. But since again the child is younger, then osteotomy should be left for a more older child, because the child will remodel and might need this surgery at a later stage. So this child underwent a simple medial hamstring lengthening, subsequent wedging in cast, and an anterior epiphysiodesis to correct the residual knee deformity, knee flexion deformity. So if we look at preoperatively, because of constant knee flexion deformity, there is an avulsion fracture of the tibial tuberosity as well as stress fractures at patella. So these gait patterns, they cause a lot of stress on the joints, apart from changing the ground reaction forces or the forces across our body, and that's how they're energy consuming gait patterns. And this knee flexion is so bad that it is capable of causing this kind of pathological fractures as well. So this was the child preoperatively. This is post hamstring lengthening, and this is around a 2-year follow-up. And if you look at how the knee from pre to currently is, it looks quite good, and he walks with support. His crouch has improved very significantly. We haven't touched the gastroc here, like sir said. If by mistake, if we don't have a 3D gait analysis and we end up doing a gastroc lengthening here, this child will become a completely non-ambulatory or a non-walker and progress into more severe crouch. So before doing a gastroc lengthening, it is very important to differentiate if it's a true equinus or an apparent equinus, and gait lab holds a very big importance when considering to differentiate between these two. So that's how what I mentioned here. So if we look at this, so this is what the normal graphs is, and here it was dorsiflexion. So that's what I meant, that lengthening a gastroc here could actually be disastrous. Coming to more complex knee pattern, which is a stiff knee gait pattern, which again requires use of 3D instrumented gait lab. And it's like these are the patterns which have been described in the books. But most of the times, our patients don't come by reading the books. They don't follow the book patterns, and the gaits are much more complex. And the crouch may be accompanied by a stiff knee gait pattern, or maybe the stiff knee gait pattern is associated with transverse plane deviations as well. So what is a stiff knee gait pattern exactly? So stiff knee gait pattern is a swing phase phenomena. So we don't look at the stance here. We are more concerned about the swing phase. It is related to the rectus muscle. And what we see is a decrease in the peak knee flexion. So this is the peak knee flexion in the swing in order to get clearance of the ground in the swing phase. So if the peak knee flexion is reduced, it is a stiff knee gait, but it has to be importantly reduced less than 45 degrees. So not a reduction of 50 or 40 or is significant. Initially, some papers do talk about below 30 degrees, but most of the times it's 45 degrees which classifies the stiff knee gait. Again, if there is a delay in the peak knee flexion, that is also a stiff knee gait pattern. So a decrease and a delay classifies the stiff knee gait pattern. Apart from this, clinically, the patient will have a prone rectus test positive, and on EMG, the rectus will be firing continuously. So like I said, that patients usually don't come along by reading the book gait patterns. And the next case, which I'll be showing you, is a child who had a stiff knee gait pattern, which is a sagittal gait pattern, and has rotational problem, which is a transverse gait pattern. So this is much more difficult part. So now from just the sagittal patterns, we come to the entire graph report. And like sir mentioned, that we don't look at one graph at a time. We have to correlate these graphs with each other. we have to rule out some possibilities. There could be some graphs which are not actually complementary with our data, and probably we have to overlook them because they might not be helpful in decision making. So let's look at this case here where we have involvement of two planes. So this is an 11-year-old child. He's a diplegic, and previously as a kid he was treated with botulinum toxin injection, and then he has undergone percutaneous myofascial lengthenings for hamstring and gastro, and again he underwent Botox injection. So now the concerns are the child has a lot of intoing. He walks well, but the problem is with a lot of the legs turning inward. So the parents have brought that he's grown tall, he was doing well. Initially, he was walking with a jump knee pattern, and now he's doing great. So when we look at him from front and we see what's happening to his feet, so both the feet are actually going inwards. And so let's look at what's the problem. So when we look at the overall clinical evaluation, what's happening with the hamstring, because since he was going into recurvatum, so how is the range of the hamstring? Is the hamstring short? Is it over lengthened, or is it weak? So there could be three stages which we could probably, looking at the hamstring, decide. And here the hamstring seems to be in a very mild, it's like, it's probably good, it's a mild contracture maybe. And concerns are there is increased internal rotation on both the sides. So the internal rotation is much more increased, and the external rotation is decreased. So many of the kids who sit W sitting, or the other countries which don't have a cross leg sitting pattern like us, most of them could have an increased internal rotation. What is important is that along with the increased internal rotation, there has to be a decrease in external rotation. And if it is less than 35, then yes, again, it is significant. Otherwise, it is not significant, and probably the body might compensate to get a neutral foot progression angle. But when such a combination exists, it is difficult that the body might contribute to getting a foot progression angle neutral, and the child might continue to walk with intoing. There is a mild equinus here, which is like around 10 degrees or so. This happens when there is, so we look at it that how this equinus is affecting the gait pattern. So we are just looking at the findings. Let's just get the findings and then correlate them with the gait, that how we need to go about them. There's a mild varus at the foot, and we look at the prone rectus test. So the prone rectus test is positive. We notice that there is a catch at around 80 degrees, and even individually the left side seems to be more pronounced as compared to the right. So this is a Duncan prone Ellis test, and when flexing the child in prone test, wherever there's a catch, this suggests of spasticity, and if there's a contracture, the knee might not bend beyond 90 degrees. So here we are dealing with a spastic rectus as well, which is causing a difficulty in. Okay, so we look at the gait pattern, how this prone rectus positive test is affecting the gait there. And like I said, in the diagnostic matrix, we need additional radiological evaluation, and a rotational CT profile is what is usually we do at our clinic and the lab to understand how the rotations are as a supplementary data to the transverse plane gait graphs. So here the femoral version was 38 on the right and 45 on the left, which is quite significantly abnormal and high, and the tibial torsion was around 26 and 25. Ideally it can be somewhere around 18 to 19, and this was not very much abnormal, but yes, this normally from 12 to 14, instead it's almost double in both the sides. So the anteversion was much more higher in both the cases. So here the primary concern, like I said, was intoing. On our evaluation, we find that there is an equinus, there is a prone rectus test, and yes, this looks like a stiff knee gait on looking at the gait pattern, and hence a 3D gait analysis is going to be very much helpful. Okay, so now we go around to see how our findings are actually like how do they look in this graph here. So when we look from the sagittal plane, it is very, again, we can see that the pelvis is anteriorly tilted, which yes, is also visible here. So it is an anterior tilt. The hip is following the normal graphs, and even here the hip looks quite good. So the hip is almost neutral in mid stance, and in the terminal stance, it should go in extension, which we see here. So which we see it does go in the, so it's following the graphs very well. When we look at the knee, it starts with mild flexion and it goes into a recurvatum. And when we look again at the swing phase problems, we see that the swing phase graphs have the peak knee flexion is not only decreased but is also delayed. So this graph should have been here, but instead they are here, and plus they should have been here and they are again here. So this is what we are dealing with, a stiffening gait pattern here. And the ankle is slightly in dorsiflexion initially, but again it shows it is not able to go into dorsiflexion during the pre-swing phase or for the clearance in plantar flexion and go again back to the dorsiflexion. So there is a limited movement at the knee, as well at the knee joint, at the ankle joint, and we see the pelvis is tilted forward. So these are all interrelated to each other. So when the rectus is overactive or the rectus is short, it is probably going to pull the pelvis anteriorly. And because of that pelvis tilted anteriorly, there's a lot of imbalance between the agonist and antagonist muscle. And that causes this imbalance at the pelvis level. Here, if the hamstrings are very strong and good, or if the child has done very good hamstring physiotherapy, probably we might overcome this problem and he could still have less of this. But since this child was probably off therapy, so we see more of these problem here. In the knee flexion, because of the rectus tightness, again, there is a constant rectus is firing even in the stance phase along with the swing phase. It doesn't let the hamstring and other muscles work the way they are supposed to work, and hence we see a recurvatum here, which is again classic of the stiffening gait pattern. And because there is decreased knee movements, the ankle goes into plantar flexion. So it is not that it is actually an equinus, but these are compensatory actions which are occurring secondary to the rectus here. So we don't need to treat this actually, but we need to actually treat this one. And apart from this, we come to an additional part now. So if you look at the coronal plane patterns, they are usually very much following the normal graph, and they are deviated only in when there is a very abnormally large leg length discrepancy, then this graph might be deviated. Otherwise, usually they follow the normative graph very easily. Here we see that there is a slight abduction, which is because of the varus the child is having. So if you notice, the child walks with a broad base gait, and instead of keeping the feet or the knees together, the knees are going away. So this signifies the varus, or it can be a false varus because of the intowing. So because the markers are placed on the fibular head this side, and if the child walks with intowing, it could it could make the markers look more anteriorly and make it look like there is a varus. So again, we need to go back, look at the gait and check, does this really make sense? Or is it just like a false report which we are seeing? So actually this is not correlating with this, and this is just like because of the intowing we get to see this. So this is not, like I said, some things we have to overlook and some things we have to just like take it with a pinch of salt kind of thing. So this is one of the things we are not going to look very much into. Coming to the rotations, yes, there is a lot of pelvic retraction and protraction. So if you see, ideally it should have been this, but there has been a reversal of the graph. And the hips, as we saw, that they were in anteversion. So looking at the CT, that is the femoral neck, which was in anteversion. And when we look at the hip rotation, it is in correlation to the pelvis or the lap and how the hip is rotating. So we see that they are more towards internal rotation rather than external rotation. So the right side is showing more internal rotation and the left is showing less, while the CT showed us left side more internal rotation on the skeletal model which the CT scan has given us. So when we look at the knee again, both of them are internally. So the patella is facing inwards. And when we look at the foot, again, both the foot progression angles are much more abnormally away from the normal, and these are internally rotated. So now we are dealing is with a knee, which is in stiffening gait, a pelvis, which is anteriorly tilted, and a rotational problem at the knee, at the hip joint. And probably even there could be sometimes a tibialis posterior involvement, which gives rise to this. So if these are not matching, then probably there is a secondary cause. So probably there could be a tibial involvement or a foot involvement. But if you look here, the differences are quite very much similar, and this makes sense that the problem is only in the hip. Suppose if this had deviated more, then probably we would think that between the knee and the foot, if there is much more change as compared to above the knee, then there could be an additional problem at the tibial level also, which can be verified by a clinical evaluation of bimalleolar axis or thigh foot angle. So we did a simple post derotation osteotomy for the child and a tibialis posterior lengthening for the left side. And this was the post-operative version. We saw pre-operatively his legs were almost touching the couch. It was almost a 90 degrees of internal rotation. His feet looked very much better with the simple tip post lengthening because the varus was from the forefoot mainly. And the post-operative CT scans did show significantly good results. And this is how the child was walking after 1 year. So I'm sorry, this is also the post and this is also the post. Actually, I wanted to post a pre 1 year. Yeah, but we see that the foot is now having a neutral foot progression angle. The tibias look straight. The varus, which was much more evident before, even without correcting, it looks much more better. And that's from the sagittal plane. And he still has an anterior pelvic tilt because we have not dealt with the stiff knee gait pattern still. So this is post-surgery now after the correction of the rotations, and we see that it's doing very well. And post this, when we removed the plate, we did a rectus surgery, a rectus lengthening, and this is 1 year post rectus surgery, that is a rectus lengthening. And we see that the swing phase rectus has significantly improved, and which we saw as the equinus before is no more an equinus, it is actually a dorsiflexion, which has actually pronounced with the knee getting better and the knee range of motion getting better. So not all of the graphs have to be treated. See, this has come back to normal and things look much more better. So if we stage out the surgeries or stage out these problems, it becomes much more easier. The rehab becomes easier for the therapist because with the plating, if we do a rectus surgery, then the rehab for the rectus becomes very difficult. So that's how it's better to stage out surgeries, although we can identify the problems together, but staging out and doing them at different phases of growth spurt also makes a lot of difference and sense. So you would like to add something?
One
Yeah.
slide back. Yeah. So I just want to again show us how gait analysis helps us the actual history of a disease. And you can see that initially it was internal rotation and rectus tightness. And once we have corrected all that, with increase in age, now you have increase in knee flexion.
Yes.
Ankle dorsiflexion, so sort of crowds developing.
Yes.
This is part of natural history of growing up. It's not, and this will need to be addressed now.
Yes.
At some point in time, where we are going to address this crouch with time to come.
So actually, here we did a gait analysis with an orthosis for him, sir, and the orthosis was actually improving this. And the next part was that actually I could use this same example, but I didn't use. But I'll show another kid that how probably a gait analysis can help us to correct this kind of a crouch which sir mentioned. Could be part of natural history and not an iatrogenic crouch maybe. And this is one of the child who is actually, this is not an actual crouch, but if you see the ankle is in mild neutral position, not dorsiflexion, but he is leaning posteriorly. He needs lot of support. And this is the same child when used a solid ankle foot orthosis walks with less support, less effort, less stress over the less support over the upper extremity. Now here if we see the father has to really pull him up, but here he's like so relaxed, he's just holding on to him and he's able to do that. So here the second part of the report, that is the kinetics, not the kinematics. What all the graphs we saw before were about the kinematics, and here what comes into role is kinetics, which helps us to identify the ankle power. And if the ankle power is significantly reduced, then we should always think of first giving an ankle foot orthosis in a child, which would help him to get upright. So here the child didn't have a fixed knee flexion deformity, but the child was still walking like this. And in this case, the kinetics is what has actually helped us to make him walk much more better with just a simple AFO. So again, this is what gait analysis could also help us in prescription of an orthosis in such weak children, or maybe kids with jump knee and jump gait pattern also. This could be very much helpful. So to conclude, I would again say that the gait analysis is like an additional or a supplementary data, or some people call it like it's a luxury to have a gait lab for people who treat cerebral palsy. And I certainly feel very lucky enough to have this luxury to treat these kids with such accuracy and such good decision making, and question our own decision making if we are really finding the right thing for them or deciding the right thing for them. And like we discussed even previously, so all the kids where the clinical findings don't match with the gait findings, they should certainly undergo a gait analysis. When there are combination of gait patterns where the child is not following the book patterns, yes, it needs a gait analysis. And when again the pelvic tilts which are not explanatory or which are difficult to decipher on a video gait analysis, should certainly be referred for a gait analysis. So with this, I conclude, and we once again thank you on behalf of Jupiter Gait Lab and CP Clinic. So thank you so much. So you would like to give some concluding remarks, sir?
So I am exciting for everybody, but I just want to tell you that this is just beginning of the journey, and those who want to enjoy the roller coaster of the graphs, going through the graphs is as enjoyable as a roller coaster. There are rides going up and down, and there are times of frustration when you feel that why are we doing gait analysis, and then there are good times when you feel when you get a right answer. But it's an enjoyable ride, and those who want to join us for the ride are most welcome to come to our gait lab, see what it is like, spend some time. And those who get inspired and want to have their own gait lab, if someone can do that, we'll be very happy.
Yes.
What's coming up, Chasanal, in the coming weeks? What are we planning?
Yes, sir. Coming weeks, we are going to be doing a roll of botulinum toxins, and then few other talks.
Okay.
So probably next one would be botulinum toxin.
Absolutely. And once all these talks are over, we also want to go into other systems, role of, say, an ophthalmologist for vision problems,
Yes.
and then role of
The multidisciplinary approach.
We'll
Yes.
go to each part of cerebral palsy one at a time.
Yes.
All of you would like.
Yes.
Neeraj, I think enough for the day. Let's end this webinar and let people have dinner and go back to sleep.
Okay, so thank you everyone for joining us, and we'll have more on the OrthoTV Cerebral Palsy series in the coming weeks. So thank you for joining.